بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. I'm Nazik Elmaika, a professor of pathology at Durman Islamic University. It's of my pleasure to present to you a small talk about pneumonia, in which we are going to discuss the pathophysiology and clinical manifestations. And in this video, we are going to recognize the epidemiology and morbidity of pneumonia, define pneumonia and types of lower respiratory tract infections. Also, we are going to understand features involved in the pathophysiology of pneumonia, recognize the entity known as community-acquired pneumonia, which is one type of pneumonia, and appreciate the spectrum of pneumonia clinical presentation. At the end, we are going to identify some complications of pneumonia. The key facts about pneumonia is that it accounts for about 15% of all deaths of children under 5 years old. It affects all or any age group, but most commonly the extremities of age, the elderly and the children. It killed more than 800,000 children in 2017. Pneumonia can be caused by microorganisms, different types, can be prevented by immunization, adequate nutrition, and by addressing environmental factors. Pneumonia caused by bacteria can be treated with antibiotics. Pneumonia is a common and serious disease. The median global incidence of clinical pneumonia is about 28% episodes per child year. This equates to an annual incidence of 150 million new cases, of which about 11 to 20 million are severe enough to require hospital admission. Pneumonia is a lower respiratory tract disease. It is an infection of the alveoli caused by microorganisms, virus or bacteria or fungi. It is not the pneumonitis, which is an immune-mediated inflammation of the alveoli. Other lower respiratory diseases are bronchitis, inflammation of the bronchi, large bronchi, or bronchiolitis, inflammation of the small bronchioles, or empyema, the virulent exudate in the pleural cavity, seen the red lining here, or abscess, which is a circumscribed collection of pus within the lung parenchyma, as appears here. Microbes constantly enter the airways, but many factors prevent colonization. These factors are the innate immune response or defense mechanisms of the body, the natural immune mechanisms. The lower respiratory tract is a ciliated tall columnar epithelium with goblet cells or mucus glands that secrete mucus. This mucus entraps the microorganisms or the foreign bodies, and the cilia clears these microorganisms. There is also immune surveillance by the B and T lymphocytes, and the intact epithelial barrier itself prevents entrance of microorganisms. And there are several secreted factors, such as the secretory surface immunoglobulin A and the surfactant protein and the defenses, all of which prevent the colonization of the microorganisms. Disrupting or overwhelming these defensive mechanisms can allow microbes to colonize the lungs, resulting in pneumonia. So the development of pneumonia requires that a pathogen reach alveoli and the host defense are overwhelmed by microorganism virulence or by inoculum size. The endogenous sources of microorganisms are the nasal carriers, sinusitis, oropharynx, gastric or tracheal colonization, and hematogenous spread from a focus within the other focus within the body. There are many factors that favor colonization. Those of the disruption of mucociliary clearance, for example, the airway obstruction, cystic fibrosis or chronic obstructive diseases, chronic bronchitis, all of which, or even neoplasms, can obstruct the airways, causing the collection of fluid and mucus and the microorganisms behind them. Or the cilia is dysfunction, and smoking, for example, causes ciliary dysfunction. Disruption of intact epithelial barrier can be caused by injury, for example, due to intubation in the operations or infections. And increasing inoculation events are the altered consciousness, debilitated diseases like diabetes, dysphagia, intubation, or bacteremia. Or decreasing immune function, for example, immune suppression in transplant patients or patients with HIV, or evading host immune due to IgA problems. Why and how inflammation define the forms, where and how inflammation appears define the forms of pneumonia. Pneumonia can be alveolar pneumonia or lobular, bronchopneumonia, interstitial pneumonia, or atypical pneumonia, depending on where and how the inflammation appears. For example, in alveolar pneumonia, the virulent exudate of the red blood cells and polymorphonuclear cells, for example, neutrophils, is seen within the alveolar lumen. The pathology is within the lumen of the alveoli in alveolar pneumonia. In lobar pneumonia, there is a lobar distribution. Only a single lobe is affected. This occurs in the typical community acquired pneumonia, and the commonest causative agents are strep pneumoniae and Haemophilus influenzae. In bronchopneumonia, there is patchy distribution of the infection, typically seen with aspiration, intubation, and bronchiectasis. The causative agents are staph, enterics, and Pseudomonas. In interstitial pneumonia, mostly the alveolar wall is affected, not the lumen. The white blood cells or mononuclear white cells are seen within the wall of the alveoli, and there is fibrinous exudate. In atypical pneumonia, there is diffuse infiltration with very high concentration, and the causative organisms are Mycoplasma, Chlamydia, Legionella, or respiratory viruses like the influenza virus. There are 4 types of pneumonia. Number 1, community acquired pneumonia, in which the onset is in community or during the first 2 days of hospitalization. Its highest incidence is in winter, and smoking is an important risk factor. Hospital-acquired pneumonia occurs more than 48 hours after admission, not incubating at the time of hospitalization. It is the highest mortality rate of nosocomial infections. It is considered of healthcare associated infections. Aspiration pneumonia can be caused by mechanical obstruction or chemical injury, and usually there is a superadded bacterial infection. In opportunistic pneumonia, the microorganisms are not virulent by themselves, but the patient's immunity is low. The commonest organisms are pneumocystic carnii, cytomegalovirus, and fungi. And patients with severe protein calorie malnutrition, immune deficiencies, chemotherapy, radiation recipients, and transplant recipients are at higher risk. We are going to talk about a bit about only community-acquired pneumonia, in which, as we said, the infection of the pulmonary parenchyma acquired from exposure in the community. Classically, it is divided into typical and atypical syndromes. The typical community-acquired pneumonia presents with typical severe acute infection. The infectious agents can be cultured or identified. Usually they are strep pneumoniae or Haemophilus influenzae. And it is responsive to cell wall active antibiotics like penicillin. While atypical community acquired pneumonia, the presentation is usually subacute, and the causative pathogens are difficult to culture or identify by standard methods, and it does not respond to penicillins and cell wall active antibiotics. The history in typical community acquired presentation is usually there is a sudden onset of fever and shortness of breath. Physical signs and symptoms include fever, tachycardia, tachypnea, productive cough with purulent sputum and possible hemoptysis, pallor and cyanosis, and there are localized signs that include dullness to percussion, decreased breath sounds, and certain breath sounds, including crackles and rhonchi. Investigations should include the chest X-ray that will show lobar consolidation, and the CBC that will show leukocytosis with left shift. Sputum sample contains neutrophils, red blood cells, gram stain may be positive depending on the organism. This is the X-ray of typical lobar community-acquired pneumonia. This is the sputum with the microorganisms, the neutrophils and microorganisms. The atypical community-acquired pneumonia usually affects young healthy patients. 1 week or of low-grade fever and sore throat and intractable cough are the common presenting symptoms. There is minimal sputum production. The patient is able to continue to work. He has no sick contracts or recent travel or evidence of altered immune system. The pulmonary examination reveals a mildly ill-appearing patient with diffuse wheezes on lung exam. Primary care physician prescribes empiric antibiotic for community-acquired pneumonia with complete resolution. The complications of pneumonia include pleural effusion, which is collection of fluid or exudate in the pleural spaces, seen here as yellowish color. It can compromise lung function. Emphysema when the clear exudate becomes greenish, there is a purulent exudate in the pleural space. There is usually necrosis, breakdown of visceral pleura, and or spread of infection into the pleura. Pleural adhesions and lung fibrosis are also complications of pneumonia, and the lung abscess is another complication or cavity formation. This is the cavity, which is a circumscribed focus liquefactive necrosis within the lung tissue. Another gross appearance of lung cavity associated with necrotizing staph or strep infection or gram-negative rods or aspiration. To summarize our talk, pneumonia is a common and serious disease, commonly affects children and elderly. Disruption or overwhelming host defense mechanisms can allow microbes to colonize the lungs, resulting in pneumonia. Where and how inflammation appears determines the forms of pneumonia that include alveolar, lobular, bronchopneumonia, interstitial, or atypical pneumonia. They are common 4 types: community-acquired, health-acquired pneumonia, aspiration, and opportunistic pneumonia. There are many complications that include pleural effusion, empyema, pleural adhesions, lung fibrosis, and abscess or cavity formation. That is all, and thank you very much. Wassalamu alaikum wa rahmatullahi wa barakatuh.